second. Right. Okay. So I'm making sure. Good evening, everyone. I think I can say confidently, good evening, South Africa, Cape Town, KZN, other parts of South Africa that I may not be aware of. My name is Zeto Makatini. I am from BMF, Besi Makatini Foundation. I don't know how many people know about this organization. It is an NPO based in Durban. It's a very small organization, and we are supporting people in the community living with dementia and their carers. So when I'm not doing that work here in the UK, I work as a family and systemic psychotherapist in a service that supports older people over 65 with mental illness and dementia. So dementia is obviously something that is my passion. I'm sure most of you who are here, it's something that people are interested in, or because their relatives or their loved one are living with the illness. So I think we're very privileged today to have a dear friend of ours called Amy Katie. So she'll introduce herself, but also I'd like to introduce Matanda, Mrs. Mabizela, who is doing a fantastic job in Durban, Lamontville, because without her, won't be able to be running this organization. So whilst I'm still here, but she's there in South Africa, because I can't be in South Africa and be in England at the same time. So I also want to say thank you to Karen from Dementia South Africa, because she's somebody that I've known over the years. So she makes sure that the people that she supports can have access to information, all these webinars and other things that we do. So welcome to everyone. And I'm not going to spend much time talking. I think Matanda may want to introduce herself, because she is a key person behind Besi Marketing Foundation in South Africa. If Matanda can just show her face and say hello, and then we can introduce Katie.
Amy. Good evening.
Amy. Yes.
Oh yes. Good evening, everybody, and I would like to welcome each and every one of you. As Zetu said, my name is Matanda. I'm a retired cardiac perfusionist. I'm now sometimes I don't even know what to call myself. It's somebody who had a parent that lived with dementia. It's somebody that said to Zetu, "Here am I, use me, teach me, and let me help people in my community and actually everywhere in South Africa." And it's such a joy to be with Zetu, and we welcome you, Amy. And we know such a topic is very important. So yeah, I'm not going to say much, but we're looking forward to hear more from Amy about young onset dementia.
Okay. So
Thank you very much.
So Amy, before you go in, please, I just want to remind people that people have got to mute themselves, because I can hear some Zoe. I don't know who Zoe is talking.
No.
So I have to find if I can mute. Sorry, I'm going to mute everybody. No, I don't want to mute you, Amy. But I think before we continue, I think we need to make sure that people remember to mute themselves. I think Zoe, I think I'm going to mute Zoe.
Yeah, I think you have.
Have I? No, I think I
yeah,
have.
It's quieter now.
Yeah, okay, but yeah, if Zoe can make sure that she's, yeah, okay, thank you so much. So anyway, sorry, Amy, about that. These things do happen. We're all human beings, we make mistakes. So please, welcome to the webinar. Yes.
Thank you for the welcome. And Zetu and Madanda, it's always really lovely to see you. Thank you everyone else for coming along. I am a dementia specialist nurse, and I've worked with people living with dementia and their families for over 20 years now. I currently run a service called Empatia, specialist dementia coaching, where I support people with the early symptoms of dementia, the family carer throughout the trajectory of the illness, and the wider family. I use dementia-specific psychological approaches to support people ultimately to build the skills and resilience to stay at home for as long as possible. But today, hang on, let me see if I can make this work. That's it. Today, as you know, I'm going to be talking about young onset dementia. This is an incredibly important topic to me, and it has been throughout the course of my career. I'm going to give you a bit of background about me so that you know I am qualified to give this presentation. We're going to talk about the semantics and the language used when we're talking about young onset dementia. We'll talk about what young onset dementia is, the challenges with diagnosing people living with young onset dementia, the unique needs of people with young onset dementia that are different to older people with dementia, and also different to people living with chronic and enduring mental illness. We're also going to look at some of the services and support that are actually available in England, and one of which is available globally. So, a bit about me. You may not have heard of the Admiral nurses in South Africa because it's quite a UK-centric model. But over here, the Admiral nurses are dementia specialist nurses that support the families of people living with dementia. Over the years, I've developed 4 Admiral nurse services in primary care, private care, social care, and the NHS. The service I developed within the NHS was based at Imperial College London, and it was a national service for young people living with dementia and their families. I've worked as a consultant nurse across Wales to advance policy, education and legislation, and I also redesigned services in certain parts of Wales to make them more person-centred for people living with dementia. Over the years, my academic career has run alongside this, and I've lectured at universities and taught countless professionals and services across the UK about dementia, ultimately so we can support people to have a better quality of life. As a result of having a national and strategic overview, I've noticed the changes in services over the years. I've seen that in certain regions, people are getting less than they actually need to support people living with dementia and their families. And this is why I created my own service, hopefully to help to meet some of those needs. So, semantics. Why is semantics? Why is a language we use important when we're talking about young onset dementia or any disease, really? We use language so we can classify a condition or a symptoms or a disease. In the case of young onset dementia, because it's not well understood and there's a lot of stigma attached to it, we need a word or a term that can encapsulate what this condition is, how the needs differ to that of other people, and it needs to be age specific. We also need a word that can help to guide policy, can help guide services and structure services, and also educate our staff. So, a word often used still today, and I do still use it. I use it to the point I might even mention it in this presentation, so I apologise if I do. It just confuses everything. Early onset dementia. We try to avoid this now because it is confusing. I've heard people with late onset dementia tell me they've got early onset dementia. What they actually mean is that they've got the early symptoms of dementia. But because it's quite a confusing term, it's often used interchangeably. Pre-senile dementia. In 1907, this term was used to describe the very first documented case of Alzheimer's disease by Dr. Alois Alzheimer. It's a very old term. We still use it today. We try to avoid it because it's heavily loaded with negative connotations. I was on a radio show a few years ago when I was talking to the interviewer about the semantics and the language we should use. They used the words senility, senile, and pre-senile countless times throughout the course of the interview, despite me trying to tell them that we try not to use that term, which suggests to me it's still used in the population, and in the least, it can be quite insulting. Young people with dementia, well, the people we're supporting are young people with dementia, so there's nothing really wrong with that, and I also use that term interchangeably. Working age dementia, we try not to use this because the bulk of people living with young onset dementia are from age 55 to 64. In the UK, a lot of these people, not a lot, but some of these people have actually retired or taken early retirement, and that works the other way too. My granddad worked into his 80s and my nan worked into her 70s. They were of working age. So we try to avoid that term because it is confusing, especially when the age of retirement in the UK is actually changing all the time now. And what we tend to use is the term young onset dementia. And because language changes constantly over time, I dare say this will be revised at some point. But for now, we need a term that can guide us, guide care, guide policy, and guide services. So, what is young onset dementia? Let's talk about what dementia is first. So, dementia is a syndrome, and a syndrome is a collection of symptoms that commonly occur together. In the case of dementia, this syndrome is caused by neurological progressive disease. I'm going to use an example, the Alzheimer's disease example, because it affects between 60 to 70%. Sorry, it causes 60 to 70% of all forms of dementia. And the syndrome of dementia is defined by cognitive symptoms because the underlying disease affects our cognitive processes. Now, as this disease advances or progresses, we see more and more disease and difficulties within more and more cognitive modalities, and that's when the disease turns into dementia. So the difference between late onset dementia and early onset dementia is nothing other than an arbitrary age. So the age being people under 65 are classed as having young onset dementia. In 2014, the prevalence of young onset dementia in the UK was estimated at 42,000. In 2022, this was revised based purely on GP practice records and a prevalence of, I think it says 70,800, but I can't see because everyone's at the side of my screen. So I'm going to pretend that the prevalence in 2022 was revised to 70,800 people. That's helpful, but we do know that across the UK, there are problems with GP coding. Even in England, not all practices are up to speed with coding diagnoses. In some countries, they don't even have a coding system to code the diagnoses. Some countries still use paper notes. Certain databases don't interact. So what we're really seeing is potentially a vast underestimation of the number of people living with young onset dementia in the UK. Now, the UK, compared to other countries, less affluent countries, has a better recording system. So if we're trying to obtain the global prevalence of people living with young onset dementia, that's incredibly difficult. And in 2021, a study estimated that the global prevalence of young onset dementia, and the age was from age 30 to 64, was 3.9 million. Now, much of these studies came from Europe, so there was a heavy Europe bias there. There were studies from Asia, South America, but the other studies from other continents had more of a bias towards people that were older with young onset dementia, i.e. their 50s and 60s. And I just want to point out there were no studies from Africa. And it's the same for this study. In 2023, a similar review estimated that around 370,000 new global cases emerged each year. This was based on similar data, European data. It was quite European centric. Now, Asia, Oceania, South America, all provided information, but it was still very heavily focused towards older people with young onset dementia. So I think what this shows is that we don't know the true number of people living with young onset dementia. And again, in this study, there was no data from Africa. And Zetu, Madanda, and I have had many conversations about the lack of understanding in Africa about dementia and why it's much more difficult for people over there. So it is rare, but dementia also occurs under age 30. About 20 years ago, we had an epidemic here. It was a bovine spongiform epidemic, otherwise known as mad cow disease. I don't know if you've had anything similar in Africa, but what tends to happen, people develop a type of dementia called Creutzfeld Jacob disease. Now, this has affected people of all ages, even young teenagers. And what they do, and they're ingesting a toxic protein from a cow that has also ingested a toxic protein. And as a result, it turns into dementia in their system. There's other ways that people can develop this condition called Creutzfeld Jacob disease, this type of dementia. That might be through a dominant gene, in that there's a 50% chance a child is going to inherit the gene, therefore the disease, if the parent carries the gene and develops the disease. And also, sometimes these cases of CJD or Creutzfeld Jacob can just appear. I found some case studies the other day for a 16-year-old and a 20 that had Creutzfeld Jacob disease that had just appeared. In Huntington's disease, we see a very, very, very rapid accelerated onset in teenagers. We call it juvenile Huntington's disease. And we do typically see much of the rarer dementias in the under 30, in the under 40 bracket, really. And I found a study recently which was quite upsetting, because a recent report from Australia showed that 1 in every 2,900 babies globally were born with childhood dementia. These dementias were caused by over 100 different types of genetic conditions. Very few of these children live beyond 10 years old. And the study also stated that it was almost as many children dying with dementia as with childhood cancer. Now, I've never heard of childhood dementia, only in the literature and briefly. But if those numbers are accurate, then there's a significant misunderstanding and stigma involved with childhood dementia. In relation to that, dominant genes are more prevalent in younger people with dementia. By that, I mean a 50% chance that dementia is going to be passed on down the generations. And that's obviously a very distressing and upsetting form of dementia. Around 5% of all cases of Alzheimer's disease are caused by a dominant gene, and between 10 and 20% of all cases of frontotemporal dementia are caused by a dominant gene. In addition, and this is where things can get quite tricky, people with young onset dementia, as Zetu pointed out earlier, experience the rarer causes of dementia and atypical presentations, which means people don't present as often with memory difficulties, so it's much harder to identify the dementia compared to identifying it with people with late onset dementia, which leads us on nicely to diagnosing young people with dementia. So, sorry, let me go to the next slide. The time from symptom onset to diagnosis of young onset dementia in the UK is around 4.4 years, compared to around 2.8 years with late onset dementia. A lot of devastation can happen within those few years. People can lose their homes, they can have a family relationship breakdown, they lose employment, they can get wrapped up in the criminal justice system. And that's because we're not diagnosing people quickly enough. Some of the reason for that is because people might present to services with visual difficulties. Now, if you're having difficulties seeing, the first place you're going to go is to the optician. And they might have symptoms quite characteristically. There's a certain type of Alzheimer's disease called Posterior Cortical Atrophy, or PCA, An author called Terry Pratchett, who was quite famous, also lived with that disease. And what we've seen in patients such as Terry Pratchett is that words or letters might be flying off the page when the person's trying to read or write, or the visual world might flip upside down, which is obviously very distressing. We might see people with restricted eye movements in the case of another rare condition called progressive supranuclear palsy. Movement disorder, when I say movement disorder, this is any movement that we shouldn't be happening that's caused by a neurological process, often seen in Parkinson's disease and dementia with Lewy body. But what we do see as well in younger people with dementia, sometimes very slight movement problems, such as, again, with progressive supranuclear palsy, we might see someone leaning, they might have a trunk lean that's very difficult to detect. Or another condition called corticobasal degeneration, people might develop alien limb syndrome. So one part of their body, the arm and the foot, might not really work. They have to drag the foot and the arm doesn't do anything. These are all symptoms of certain neurological conditions. And in the case of frontotemporal dementia, there is one gene that also causes motor neurone disease to co-occur with that type of dementia. Again, you wouldn't expect a 40-year-old who's probably got a bit of a lean coming into your clinic to have dementia. In fact, it's probably the last thing that you'd consider as a clinician. Language difficulties, that in many cases, the primary symptoms are language symptoms in that the language changes, but it's also important to point out that as dementia advances, people will always have language difficulties. And what we might see in early stages of a younger person with a language type of dementia, they might have difficulties finding words, they might have difficulty identifying objects or nouns. Some people talk about the tip of the tongue phenomenon, where you can see an object, you know what it is, but you cannot recall the word for it. People might have difficulty producing sentences, or they might not have difficulty producing sentences, but they might put the wrong words in the place of the word that should be there. And also, people can use less and less words, which then can develop into mutism. Probably not something we'd associate. If I walked into a clinic with language problems, the GP wouldn't look at me and think she's probably got dementia. Behavioural and personality changes. I've known people with frontotemporal dementia to just up and leave their family a few years before diagnosis. I knew one person who decided to travel around another continent. I'm pretty sure they didn't do very good of travelling around the continent, but they did get back in one piece, and a spouse and their adolescent children then looked after them because they realised it was a brain disease. People can become very obsessive, very ritualistic. People have developed gambling issues, gambling away a lot of the family money. I've seen people develop quite significant alcohol problems. I've seen people change from being a very reserved, shy person to being very exuberant and quite grandiose. And again, these are often the symptoms of frontal lobe changes. And these symptoms can be classed as mental health difficulties to the eye that doesn't recognise them. Often, we do know that leading up to dementia, in a lot of cases, people can develop, not dementia, they can develop depression or anxiety or apathy. And obviously, if you're presenting to services with these conditions, you are quite rightly going to be diagnosed with depression or anxiety. And then it's unlikely that dementia would be considered after that. People are often, actually, in the case of frontotemporal dementia, diagnosed with bipolar affective disorder because they can have manic episodes, or, like I said, they become quite exuberant and grandiose. People, well, going back to Dr. Alois Alzheimer in 1907, his patient, the first documented person to have Alzheimer's disease, actually presented with paranoid psychosis. They were her initial symptoms. So we see paranoia, we see psychosis. And often when people go to the GP with these troubles, knowing there's something wrong, the GP will understandably say they're probably menopausal or stressed, it's work stress or depression, because it's not expected in younger people. And this is where I'm going to talk about the Alzheimer's disease phenotypes, or the Alzheimer's disease variants. So the most common cause of dementia in all ages is Alzheimer's disease. And we recognise that due to memory difficulties based on the part of the brain that is affected, usually records information of day-to-day events. It records information about unemotional conversations we've had. It will record information about driving to work or what we ate for dinner. And because this part of the brain's diseased, this is where you see people repeating and repeating and repeating, but they might remember a poignant aspect of a film or a program they watched the night before. And this is quite confusing to families. They might forget what they've eaten. You say, have you eaten anything? And they'll say, yeah, I've eaten loads and they've not eaten anything. You know, this is where risks can come about. And the most common variant of Alzheimer's disease is that variant. It's called the amnestic version, which basically means it's the memory presentation of Alzheimer's disease. In older people, you're more likely to expect to see that. And you're more likely to see that presentation. With younger people, that's not always the presentation we see, although it is the most common. This same disease underlying the cognitive changes, the toxic beta amyloid and dysfunctional tau, which are characteristic of Alzheimer's disease, actually underlie other conditions too. So, amnestic AD is at the top, the most common type of dementia, and it starts near a part of the brain called the hippocampus. It's called the hippocampus because it means seahorse in Latin. Well, it used to. Now, that same disease can also present in the form of Alzheimer's disease called logopenic aphasia, which is a primary progressive aphasia, which means the first symptom is language difficulties, and then that advances over time. So language becomes more and more impaired. The left side of the brain is typically where the disease happens, because that's where we produce, we learn, and we comprehend language. And that is the same disease as Alzheimer's disease that we all know of. Posterior Cortical Atrophy, or PCA, this is Alzheimer's disease too, except it affects the back of your brain, because we see with the back of our brain. This is a disease that Terry Pratchett had. Alzheimer's disease affects the visual lobe, and that's why we see the symptoms such as words flying off the page or the visual world flipping upside down. And then the Alzheimer's disease variant of Corticobasal Syndrome. This describes a group of disorders that cause problems in swallowing, in movement. It can cause jerking behaviours. And often, Corticobasal syndrome is caused by a different disease called corticobasal degeneration. But Alzheimer's disease can also cause the same symptoms. And there's a pattern there. What we're seeing are diseases that are caused by different underlying pathologies, if you like. The changes in the brain are caused by different underlying pathologies, but you're getting the same presentation when people go to the clinic. Finally, the behavioural or dysexecutive variant of Alzheimer's disease affects the frontal part of the brain. Now, we don't associate frontotemporal dementia with Alzheimer's disease. But what we see when we see the dysexecutive form of Alzheimer's disease are exactly the same behaviours. Someone struggles to plan, they struggle to problem solve, their risk awareness goes, they can become disinhibited, they can participate in risky or behaviour that's beyond their typical norm, if you like. Or if it affects the other side of the frontal lobe, then the opposite happens. The person becomes apathetic, the starter motor goes, and all tasks need to be done for them because they're unable to do it for themselves anymore. They haven't got the inclination to want to do it for themselves. So this is a problem because it's hard enough to recognise dementia in younger people, but to actually try to recognise the type of dementia based on the specific disease, because ideally you can treat that. If we know that someone has Alzheimer's disease pathology, they can be pushed forward to clinical trials. But if you're a typical memory clinic across the UK, often a few cognitive screening tools are used, which are very good, but they are supported then by MRI scans or CT scans for the most part, which are helpful, but they're not very sensitive or specific in diagnosing the underlying pathology. I was very fortunate to have worked at Imperial College London, where we had access to amyloid imaging. So we could see early changes, toxic amyloid building up in the brain when people's early symptoms appeared. And remember, the average is 4.4 years from symptom onset until diagnosis. 4.4 years is a long time that you can buy someone. Someone can have time to live, they can spend time with their family, they can plan, and I've seen it if they've got that time. Because the resources in the UK are not really as sensitive or specific as we'd like them to be, and recognition is not as good as it could be, people are losing valuable years for their life. And also, if you've got someone that comes into a clinic who is very intelligent and you go through the typical screening test with them, they might quite easily pass all the tests that are asked that are looking at each cognitive domain, because their intellect can override and mask any difficulties. And it's the same with people that have got a very good social front. It's very difficult to detect dementia. And in some cases, people might not even get anywhere near a memory clinic because the changes are behaviour, a lack of awareness or insight into what's going on. And in that case, it's just the family that begin to struggle. So, as I've said, the needs of people with young onset dementia are very different to people with late onset dementia. Earlier at the beginning of the presentation, I talked about the distinction between late onset dementia and chronic and enduring mental health. And I made this distinction because services in the UK are separated into either adult mental health or older people mental health and dementia, or just dementia. Very few places specialise in supporting young people living with dementia with a very different set of needs, such as they're physically fitter. I worked with one chap, he was 6'3", he was in his 40s, he was a footballer, and he walked 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 to places he shouldn't have been walking to that got him in a lot of trouble. He didn't do it with any intent. He was walking because a neurological symptom called perseveration with frontotemporal dementia will constantly result in you repeating and repeating and repeating the same thing. How can a day centre or a care home support someone like that? Because his needs were so complex, the poor man ended up in a care home quite early because he couldn't be managed at home. There had children in the home, but a care home would really struggle to support somebody like that. Younger people have got less comorbidities, which means generally our health is better. As people age, it's common for us to experience more and more different health difficulties. So the lack of health problems, or the lesser health problems, add to people's physical fitness. We're still looking at a group of people who are a lot fitter, that services really need to find a different way of supporting. Often younger people have got young children or adolescent children. I mean, this is absolutely heartbreaking. I can't imagine being a mother of children knowing that I've got a neurological progressive disease. I've worked with, I think some of the most heartbreaking cases I've worked with over the years are single parents with young onset dementia. I've had to case coordinate to include social services, sorry, child and adult social services, GPs, headmasters, specialists, family members, safeguarding teams. Also, we could try our hardest to keep the person with their children or child together for longer, and it's very upsetting. Dominant genes in relation to what we were talking about with regards to children and adolescents. I did say earlier on that there's a higher number of dominant genes that cause certain types of dementia in younger people. And those of us who've worked with younger people with dementia have worked with people knowing that there's a 50% chance that the child may also develop the disease too. People are dependent on employment. Young people are dependent on employment because they need to pay their rent, they need to pay their mortgage, they need to pay for their car, they need to pay for their children's schooling. Over time with dementia, you struggle to work. And also that sometimes the legislation that's there to protect people is not always used effectively. I've had to intervene on a number of occasions because under the Equality Act, employers are supposed to make adaptations in the workplace to keep people in work for as long as possible. Again, because the workplace doesn't understand dementia, workplaces will try to avoid doing this. Not all, I hasten to add, but a few, and sadly, even in some of the professions, this has happened. So, who's supporting these people to stay and work? In addition, employment gives us a sense of meaning, it gives us a sense of purpose, it gives us identity. We need to try and keep young people with dementia working for as long as possible. I just said people need the mortgage, they need to pay the mortgage, they need to pay rent. Many times I've seen houses sold because the family carer gets to a point where they have to give up work as well as a person with dementia to continue caring for their loved one. And we're in a time where people have many responsibilities. If it's not someone managing a career and children, it'll be someone who's probably in their 50s and 60s, looking after parents, looking after children, looking after grandparents. People have many responsibilities. And if the person managing all those responsibilities becomes ill, that has a domino effect and affects everyone else in the family. People with dementia that are single and living alone, and I mean people that have never had children. I've worked with a number of single people. I've had friends ringing me to tell me their friend can't see the curb when they're driving and they're worried, or they're often going for walks and nobody knows where they've been, but then they'll come back again. There's nobody to check in with them, or they're drinking more alcohol, they're stubbing cigarettes out but not properly putting them out. And the problem is, being single and living alone, as the disease advances, they're exposed to more and more risks. A key issue underlying all of this is the stigma and the limited awareness on these topics. People with young onset dementia often feel like they've got an older person's disease and they shouldn't have it, so they feel really ashamed. People see dementia as something that affects memory, so it's even more confusing and stigmatizing to them. I've known people that I supported in the past to be told by other people that they knew when they told them that they had dementia that they don't have dementia. I mean, that's really invalidating. And stigma creates a lot more problems than we actually realise. So before the lockdown, I developed a support group for people with Alzheimer's disease, young people with Alzheimer's disease. This was people with one person with posterior cortical atrophy, one person with logopenic Alzheimer's disease, and the others all had amnestic variant Alzheimer's disease, the normal Alzheimer's disease that we're aware of. And with dementia or Alzheimer's disease, if you're living with a condition like this, a lot of the time people are in a chronic state of anxiety because of the level of insecurity they feel. In this group, these people together, their anxiety reduced and their symptoms seemed much less advanced because they felt stronger, they felt completely understood by each other. And at Christmas before the lockdown, they all went out together. It was a very stressful night for me knowing this because I don't know, I was worried they wouldn't get back, but they did. And they were a force to be reckoned with. But tragically, after the lockdown, only one person was still well enough to probably return to the group. Services for people and families with young onset dementia. Why do we need different services? Why do we need better services? Because we're not meeting the needs of young people with dementia. And I don't think that's just the UK. I don't think that's just Africa. I think that's many places that aren't meeting the needs of these people with their unique set of needs. I've worked across the UK in various places over the years, and just to give you an idea of the variability that I've seen, I've worked in places where there's overdiagnosis of young people with dementia, and a lot of people was walking around with symptoms that really didn't look very much like dementia, if I'm honest. Obviously, in a lot of ethnic communities, it's really hard to get people to engage because of the stigma that they experience within their own communities and the fear of English healthcare services. And there's regions where it can take many years of the family carer fighting for someone to get a diagnosis. But additionally, there's also some excellent practice, not just across the UK, but across the globe. I'm only mentioning 3, and I apologise if there's people out there that also know of exemplary services that I haven't mentioned. I'm doing it to keep it short. But the Younger People with Dementia charity in Berkshire, originally in Berkshire, now also in Surrey, is absolutely outstanding. They support people with dementia by undertaking activities that are age appropriate, fitness appropriate. They will go canoeing, they go out walking, they go bowling. I think Zetu and I were invited to bowling with them. I pretended that I couldn't go on that day, but I just don't really want to embarrass myself and go bowling. They're cooking. There's so much that they do, and then there's also specific support for the family carers to give them some rest. They provide education and training. They're an absolutely excellent charity, and it's possible now that they've spread beyond just Berkshire and Surrey, hopefully. In Northamptonshire, within the NHS, there's a nurse-led young people with dementia service, young onset dementia service. They have been running for over 20 years. They are nurse-led, they've got occupational therapy within the team and healthcare assistants. They diagnose and provide ongoing care to young people living with dementia. And then finally, there's the National Brain Appeal. It's a charity that funds a section of the charity called the Rare Dementia Support. It has a global reach, and it provides support for people with rare dementias and family carers by putting on seminars, education and support groups, and they focus on a few key areas such as frontotemporal dementia, then separately primary progressive aphasia, which is the language dementias. Then they look at young onset Alzheimer's disease, familial onset Alzheimer's disease, and dementia with Lewy bodies. I think there's another, and they strictly support those rarer dementias. So, finally, I've just left you with a leaflet, flyer that you might be interested in. I'm running a workshop on the 12th of November. It's not a workshop, it's more of an advice and support session, actually. and it's to help family members get through the winter. I'm mindful that I'm talking to people in South Africa who probably don't have winters like we do. So this is about supporting people to identify the risks, supporting the family carers to identify and manage the risks associated with winter, such as their loved one leaving home and getting lost, the hospitals and primary care being absolutely overwhelmed. It's about supporting people to stay well, to reduce the risk of delirium and falls. The last thing anyone wants over the winter months is their loved one being admitted to hospital, being stuck in there for months and months and months because they can't get the aftercare support to get them out, and then they decline throughout. And also, it's to help people through the festive season. Christmas, the festive season is incredibly overwhelming for any of us, really. But if you've got dementia and you can't filter out all the lights, the noise, the people around you, and you're feeling sad because you can't participate in the festivities as you want to, you're probably going to get a little bit agitated and overwhelmed. And it's about supporting the family carers to identify this and look at ways we can manage it ultimately, so everyone in the family has the best festive season that they can, and people survive the winter with as few risks and difficulties as possible. And that is the end of the presentation. Does anybody have any questions? I don't even know what the time is, sorry.
Well, it is almost 9 o'clock in South Africa, but thank you so much again, Amy. Fascinating subject. I'm sure a lot of people are surprised that there's so many different types of dementia. I'm not going to spend much time. I'd like to invite people to ask questions if they'd like to. But like I said, if people left their email addresses, I can make sure that once this has been sorted out in terms of recorded, and then I'll make sure that people are sent the link, then they can be able to watch Amy again as many times as they want.
Good luck with that.
Yeah, so I mean, I'd like to open the floor now to everyone who'd like to ask a question, but Madanda, is there something that you'd like to say before we finish?
Wow. Again, thank you so much, Amy, for such a presentation. I mean, there's one key thing that you mentioned, that even in diagnosis and understanding of young onset dementia, the key issue here is stigma.
Yeah.
And this is what we are struggling with. So far, I was talking to Zetu that just yesterday, we had a client that called in and is 60 years old. And her memory, I was saying to Zetu, is, her memory loss is a plus plus. So, and I've asked the family, have you been to the hospital? No. So how have you been coping? We just, only until we heard on the radio you talking about this disease, and we thought these are similar symptoms. So you find that because of stigma, people, they don't access, either hospital for diagnosis, even to get support that you're talking about here. So families, sometimes they just live with people and not understanding what dementia is and even how to care. So stigma is an issue.
Thank you. Thanks, Matan. I've just seen someone who's written, can diabetes contribute to dementia?
It increases the risk. It doesn't necessarily determine that somebody's going to develop dementia, but what happens is, because when we talk about old age Alzheimer's disease, dominant genes are typically not involved. So there's not a 50% chance that you're going to develop it from mum or dad. It doesn't work like that mostly in older people. But there's genetic combinations that increase the risk. Now, if someone has some of these risk factor genes and then they develop diabetes, the risk has probably increased. But it doesn't mean you're going to develop dementia. What you can take away from this is that if certain things such as diabetes, actually without them being there the risk is reduced, then this can encourage us to try our best. I'm not very good at it because I like red wine, but to try our best to live a healthier lifestyle, because we can't, if we're going to develop dementia, we can't get rid of it, but there are risk factors that can be reduced to reduce the risk of us developing it. Does that make sense? I'm not sure if I explained myself
Well, I think you
well.
did. You explained very well. I mean, the person is not going to write there. I mean, hypertension, there's a lot of vascular risk factors. And I always joke, and I shouldn't be saying that I joke, you know, when we do the screening, because we do screen people, you know, in the community. And I've always said to Madanda, I could say 99.9999% they've got diabetes, hypertension. And then you kind of know the risk factors. And these are things that people can manage. They can kind of do something about it. It's not like age where you can't do anything about age, you know, because as you get older, the chance of developing dementia is very high. But for me, I just want to go back to this point of a young onset dementia, because it is a subject that we don't talk much about, you know, in our communities, and people are also not aware of different types of dementia. So there are a lot of people who are messed up because, you know, people don't understand. We always look for older people who are forgetful, and then we can say, yes, this is dementia. But there may be people who are living with dementia who are younger, but people will say it can't be dementia because they're not old. So I think awareness is a key. I think we need to continue as a community to talk more about the illness, to educate people. This kind of forums is also another way of actually reaching out to as many people as possible. And that is why I appreciate people like Amy and other colleagues of mine, you know, who come on a Sunday, or we've got another one, Understanding Mental Illness, which is going to be on a Sunday for people who may be interested. You know, psychiatry is going to be talking about older people and mental illness, because we do not believe that older people can develop mental illness. Again, stigma, they're kind of hidden. So I think having more of these conversations is very, very important. And for me, I will urge people who are here to also come up with different topics that they really would like us to talk about. And we can use this forum as a way of actually, you know, talking about this condition where very, very few people know about, especially in our part of the world. I'm not saying in England, people know about it because I work with them, and most people still don't know, but, you know, it's very different because they could get the support. You know, it depends also where they live. But in South Africa, we've got a long way to go. So, and that's why I appreciate all the support from colleagues of mine who give their time to actually meet with others here and say, let's learn together, because dementia knows no boundaries. It doesn't matter whether we are rich or poor, we are white or black, you know, it does have an impact on families. At the end of the day, we're human beings and we're people, and we have to be here to support each other. And yeah, and move forward in that kind of way, and have the Ubuntu, which is what I like. You know, that's what we need, to care about each other and have compassion and support those ones who may be struggling. So I don't know, on that note, I don't know whether anybody wants to say something so that people can go to bed and prepare for tomorrow's work. Is there anybody who wants to say something, or people are too shy, or they're exhausted? Hello? Okay.
That's it.
Yeah, that's it. Well, just to say thank you so much again. I hope to see some people on Sunday when we have another webinar. Again, thank you so much, Amy. So this is
Thank you,
recorded.
everyone.
Yes, thank you so much. Fascinating. I'm sure we're going to have more conversation after this. Yes, thank you so much. So good
Thank you.
evening,
Take care, everyone. See you.
Thanks, Amy.
Yes, yeah, thank you. Right.